Right now, while you sit here watching this, something is happening inside your body that most adults over 60 never connect to anything serious. You wake up. Your mouth feels like sandpaper, like every drop of moisture was pulled from you overnight. You reach for a glass of water. It helps for about 30 seconds. Then the dryness settles back in, and you tell yourself it is just aging. It is just the way mornings feel now. You have been telling yourself that for months, maybe years. But here is what nobody has told you. That feeling has nothing to do with how much you drank the night before. In some cases, it is your body trying to warn you about something happening in your kidneys, your heart, or your brain right now. Something that, if you catch today, is absolutely manageable. Something that, if you keep dismissing as just getting older, the window for easy intervention starts closing. And here is the number that stops me every time I think about it. Chronic morning dry mouth affects nearly 1 in 3 adults over the age of 60. 1 in 3. And in the overwhelming majority of cases, it has absolutely nothing to do with hydration. Nothing. And yet this conversation is not happening at most annual checkups. It is not happening in the 7 minutes the average appointment allows for anything beyond the obvious. So it falls through the cracks. And you keep waking up with that sandpaper feeling. And nothing changes. There are 7 causes behind morning dry mouth in adults over 60. And the number 1 cause on this list? It is sitting quietly in your medicine cabinet right now. It affects the same neurotransmitter your brain uses to form memories. And most of the people taking it have never been told, not once. Stay with me to the end, because number 1 changes everything. But first, have you ever had a doctor actually sit down and explain morning dry mouth to you? Not mention it in passing, actually explain it. Type yes or no in the comments right now. I read every single one, and your answer helps someone else watching this feel like they are not alone. Now, let me tell you something about saliva that most people have never once heard in a doctor's office. Saliva is not simply water. Think of it as a living shield, a sophisticated biological fluid that carries enzymes, antimicrobial proteins, minerals, and protective compounds that defend your teeth, your gums, your throat, your digestion, and your immune system around the clock. Every single night while you sleep, that shield is actively working for you. When salivary glands begin to slow down, or when other systems in the body start to struggle, saliva production falls, and when it falls significantly, your mouth dries out, especially overnight, when you are not drinking, not speaking, not doing anything to stimulate flow naturally. After 60, your body already produces roughly 30 to 40% less saliva than it did in your 40s. 30 to 40%. That is your new baseline before anything else goes wrong. Already reduced, already vulnerable, and when one of these 7 causes layers on top of that, the effects reach far beyond a dry mouth. Let me tell you about someone before we begin. Margaret is 71, a retired school librarian. She came in about something else entirely and mentioned the dry mouth almost as she was leaving, almost as an afterthought. The way people mention things they have decided are not worth a doctor's time. I asked a few questions. Those questions changed the entire trajectory of her health. I will come back to Margaret at several points in this video. But first, here is what concerns me most as a clinician. Chronic dry mouth is associated with a 45% higher risk of systemic infection in adults over 60. Saliva is your mouth's frontline immune defense. Remove it, and bacteria, fungi, and viruses gain a direct path into your bloodstream. So let us go through all 7. From the most common to the one that worries me most. And by the time we finish, you will know exactly what to watch for, what to say to your doctor, and what you can do differently starting tonight. Number 7 on this list is the most common cause I see, and also the most dismissed. Mouth breathing during sleep. I know what you are thinking. That sounds too simple, maybe even obvious. Bear with me for 60 seconds, because what comes next will change how you see this symptom forever. Mouth breathing during sleep is almost never just a habit. In my clinical experience, it is nearly always a symptom of something else going on underneath. And that distinction matters enormously. When you breathe through your mouth overnight, air moves directly across your tongue, your palate, and the back of your throat. At a constant rate, your salivary glands simply cannot keep pace with while you sleep. The result is that sandpaper feeling every morning. Cracked lips, a thick or coated tongue, sometimes a sore throat with no illness attached to it. But here is the critical part. Mouth breathing during sleep is frequently driven by nasal congestion, a deviated septum, nasal polyps, or sleep apnea. And sleep apnea in particular is not something to wave away. Research shows that untreated sleep apnea is linked to a 60% increased risk of stroke and a 40% increased risk of heart failure. 60%. Let that sink in. If you are waking up with a dry mouth, and you also snore, and you feel unrested after a full night's sleep, or if someone close to you has noticed you sometimes stop breathing during the night, please do not file that away as just the way you sleep. Speak with your doctor about a sleep study. That single conversation could matter more than anything else I tell you today. For those whose mouth breathing is not connected to sleep apnea, the practical solutions are straightforward, and they work quickly. A nasal strip worn across the bridge of your nose before bed increases nasal airflow significantly, encouraging your body to breathe the way it was designed to. A humidifier in your bedroom set between 40 and 50% humidity reduces overnight moisture loss dramatically. Switching to a side sleeping position reduces the tendency to breathe through your mouth. And a small strip of surgical tape placed vertically over the lips before sleep, something sleep specialists have used for years, gently trains mouth breathers back toward nasal breathing. Most people notice a real difference within 1 week, not 2 months, 1 week. But if you think number 7 is surprising, wait until you hear number 6. Because this one is the mistake I see most consistently. And it feels completely logical until you understand why it does not work. Number 6, the water timing problem. Most people who wake up with a dry mouth assume the fix is simple. Drink more water before bed. So they do exactly that. Large glass at 10 in the evening. Wake up just as dry, sometimes more frustrated, because they did everything right and nothing changed. Here is why that does not work. And I need you to really hear this. Your body does not hydrate in real time. When you drink water, it takes between 30 minutes and 2 hours for that fluid to be absorbed, distributed to your tissues, and made available for functions like saliva production. Water consumed at 10 at night is doing almost nothing for your mouth at 6 the next morning. The window has already closed. The real problem is what happened, or did not happen, in the afternoon. Research found that adults over 60 who did not maintain adequate fluid intake between noon and 4 in the afternoon were 62% more likely to experience significant overnight dry mouth compared to those who stayed consistently hydrated through the day. 62%. That is not a marginal difference. That is a defining difference. And here is the part that nobody mentions. After 60, the body's thirst mechanism becomes genuinely less reliable with age. You can be meaningfully dehydrated and feel absolutely no urge to drink. Many people also quietly reduce afternoon fluids to avoid nighttime bathroom trips. Completely understandable, deeply relatable. But it creates a hydration deficit that peaks precisely at the moment you have no way to correct it. The solution is not more water at night. It is front-loading hydration earlier in the day. 6 to 8 ounces with every meal and every afternoon snack. Set a reminder on your phone at 2 p.m. if you need one. And here is a small but effective addition. A pinch of sea salt and a squeeze of fresh lemon in your afternoon water. This supports electrolyte balance, helping your cells actually hold the fluid you consume rather than letting it pass straight through. Simple. Costs almost nothing. Now, back to Margaret. When I asked if she was waking at night to use the bathroom, she nodded, regularly, more than once most nights. Unusual afternoon fatigue? She paused. Yes, actually yes. A heavy, pulling tiredness that came on around 3 p.m. Another doctor had told her that was simply normal aging. I asked one more question. Had she noticed any unusual increase in thirst during the day, even after drinking? She looked at me and said, "How did you know?" I ordered a fasting blood glucose panel that same week. And I want to tell you exactly what came back. But first, if this information is reaching you today, please hit like so the algorithm shows this to someone who actually needs it. Then I will tell you Margaret's results. Number 5, the nutritional deficiency nobody connects to a dry mouth. Here is what I want you to understand before I walk you through this. Your salivary glands are not passive plumbing. They are metabolically active tissues. They require specific nutrients to function at the cellular level. And 2 particular deficiencies tear through salivary gland function in adults over 60 faster than almost anything else. The first is vitamin A. This nutrient is essential for maintaining the health and integrity of every mucous membrane in your body, the lining of your mouth, your throat, your nasal passages, your digestive tract. When vitamin A levels fall, those membranes become thinner, drier, and progressively less functional. Research found that adults over 60 with low vitamin A levels showed a 41% reduction in resting saliva production compared to those with adequate levels. Not a subtle effect. That is your salivary glands running at less than 60% of their designed capacity. The second is the B vitamins, specifically B3, known as niacin, and B12. Niacin deficiency directly disrupts the nervous system signals that trigger saliva production in the first place. B12 deficiency causes the tongue to become inflamed, abnormally smooth, and persistently dry, a condition called glossitis. And here is the part that genuinely staggered me the first time I saw this data. Research suggests up to 30% of older adults have inadequate B12 levels with absolutely no awareness of it. 30%, nearly 1 in 3. After 60, B12 absorption drops significantly because stomach acid production decreases with age. Stomach acid is what breaks down the protein bond that keeps B12 from being absorbed. Less acid means less absorption. Regardless of how much B12 you eat, you could be eating well and still be profoundly deficient. This is not a diet failure. It is a physiology change that nobody warned you about. For dietary sources, focus on sweet potatoes, dark leafy greens, and eggs for vitamin A. Lean meats, fish, and dairy for B12. For many adults, over 60 supplementation is also necessary. Look for a B complex containing at least 1,000 micrograms of B12 in methylcobalamin form. That is the most bioavailable version available. The cheaper cyanocobalamin form is absorbed far less efficiently in older adults. And remember, vitamin A is fat-soluble. It absorbs dramatically more effectively alongside a small amount of healthy fat. A drizzle of olive oil or a few slices of avocado with your meal makes a genuine measurable difference. Number 4, and this is the pairing I take most seriously in my entire clinical practice. Pay close attention to this next part. If you are waking up with a dry mouth and you are also getting up to urinate more than once during the night, that specific combination is a clinical warning flag I do not ignore. Not ever. Together, those two symptoms are among the earliest signs of uncontrolled blood sugar, and in some cases, undiagnosed type 2 diabetes that has been silently progressing for months or years. Here is the mechanism. Think of your kidneys like an overwhelmed filtration system working far beyond its designed load. When blood sugar climbs above a certain threshold, the kidneys work overtime to filter and excrete the excess glucose. To do that, they pull water from the body's tissues. That internal fluid loss dehydrates you from the inside out. And one of the first places you feel it is in your mouth, at 3 in the morning, when there is absolutely nothing you can do to compensate. And here is what makes this so clinically important. Research found morning dry mouth was reported by 63% of adults newly diagnosed with type 2 diabetes. And most of them had been experiencing that symptom for over a year before their diagnosis. Over a year of their body sending a warning signal every single morning, unread, dismissed, or simply never connected to anything that mattered. Now, Margaret's fasting blood glucose came back at 148 milligrams per deciliter. Normal fasting glucose is below 100. Pre-diabetes begins at 100. Full type 2 diabetes is diagnosed at 126 or above. Margaret was at 148. She had type 2 diabetes, had been living with it unknowingly for well over a year. She sat very still when I told her. Then after a long pause, she said quietly, "I thought the dry mouth was nothing." It was not nothing. I also want to tell you what happened next, because this is the part most doctors do not have time to explain. We built a targeted protocol. Dietary changes focused on eliminating refined carbohydrates and prioritizing fiber and protein at every meal. Daily movement, not intense exercise. Simply 30 minutes of walking after the largest meal of the day, which research shows is one of the single most effective interventions for blood sugar control available. And supplementation with berberine 500 milligrams with meals, along with magnesium glycinate 300 milligrams before bed. Within 4 months, her fasting glucose had normalized completely. At her follow-up, she told me, "I finally feel like my body is working with me again instead of against me." Now I need to be crystal clear about berberine. If you are taking metformin, insulin, or any glucose-lowering medication, berberine can push your blood sugar dangerously low when combined with those drugs. Start at 500 milligrams with meals only. Do not exceed 1,500 milligrams daily, and please discuss with your doctor before adding it. That is not optional guidance, that is patient safety. Bring this video if you need to. Number 3, a condition that affects approximately 4 million Americans right now. And the average patient waits nearly 3 years from the moment their very first symptom appears to the moment they finally receive the correct diagnosis. 3 years. That is not a gap in medicine. That is a gap in the conversations happening inside examination rooms that have 7 minutes to cover everything. Here is what I want you to understand before this next section. A condition called Sjögren syndrome is an autoimmune disorder in which the immune system mistakenly attacks the body's own moisture-producing glands, primarily the salivary glands and the tear glands. The result is persistent dry mouth, chronic dry eyes, difficulty swallowing, and in more advanced cases, systemic involvement, including joint pain, fatigue, and effects on the kidneys and lungs. Women over 60 represent nearly 90% of all diagnosed cases. So why does it take 3 years to find? Because each symptom gets treated in isolation. The dry mouth gets dismissed as aging or dehydration. The dry eyes get blamed on screen time or seasonal allergies. The joint pain gets labeled as arthritis. No single provider ever connects the dots. And the underlying autoimmune process continues unchecked the entire time, doing quiet damage. The diagnostic clue I want you to carry out of this video. If your dry mouth is consistently accompanied by eyes that feel dry, gritty, or like there is sand under your eyelids, and particularly if you are a woman over 60, ask your doctor specifically about Sjögren syndrome by name. Write it down before your appointment if you need to. Sjögren. A blood test measuring 2 specific antibodies called anti-SSA and anti-SSB can identify the condition in most cases. You are entitled to ask for that test. Do not wait for someone to think of offering it. There is no cure for Sjögren syndrome, but there are effective treatments that manage symptoms and slow progression significantly. And for immediate relief while you pursue answers, sugar-free gum containing xylitol is one of the most accessible and underused tools available without any prescription. It stimulates saliva production mechanically and simultaneously inhibits the cavity-causing bacteria that a dry mouth environment actively encourages. Keep it on your nightstand. Keep it in your pocket. Number 2 is the one that stopped me when I first fully understood what the research was saying. And I almost did not include this in this video, but you need to know. Here is what I want you to understand before I explain this. Your salivary glands are governed by the autonomic nervous system, specifically the parasympathetic branch, which oversees your body's rest, recovery, and digestive functions. Think of it as the background electrical grid that keeps everything running quietly without you having to think about it. When that system becomes compromised, salivary activity declines, digestion slows, and the mouth dries out. What makes this so significant is that autonomic nervous system dysfunction is now recognized as an early feature of Parkinson's disease and Lewy body dementia. Early, not late stage, not obvious stage, early. And research has shown these autonomic changes can appear 4 to 6 years before the classical motor symptoms, the tremors, the rigidity, the movement changes, that eventually leads someone to a diagnosis, 4 to 6 years before. Other autonomic changes that may appear alongside dry mouth include loss of sense of smell, constipation that seems to have no digestive explanation, and a significant drop in blood pressure when you stand up too quickly. Now I need to tell you something. Not to frighten you, but because this specific piece of information gave one of my patients 3 additional years of preparation and quality of life that he would otherwise never have had. He was a retired man in his late 70s, methodical, quietly observant. He had mentioned a persistent dry mouth across several visits over more than a year. We had worked through the obvious explanations together. Sleep position, hydration timing, medication review, nothing fully resolved it. He kept a small notebook by the bed and had been tracking his morning symptoms with the precision of someone who trusted data more than impressions. He showed me the pages at one visit, weeks of consistent notation. Then at one appointment his wife mentioned, almost in passing, that he had stopped recognizing the smell of his morning coffee. Not that the coffee smelled different, that the smell was simply gone. He had noticed it himself for months. He said nothing. He assumed it was completely unrelated to everything else. It was not unrelated. I referred him to a neurologist immediately. Imaging confirmed early-stage Parkinson's disease. He was shaken when we spoke about it, genuinely shaken. But because we found it early, he was able to begin neuroprotective therapy and build a comprehensive care plan with his family well before significant motor symptoms developed. 3 years later, his quality of life remains genuinely good. He still walks every morning, he told me at a recent visit. I almost didn't mention the dry mouth. I thought it was too small to bring up. Nothing is too small. Your body is always communicating with you in the only language it knows. Our job, yours and mine together, is to learn how to listen. And now, number 1. The cause I encounter most frequently in practice, the one most consistently overlooked, the one most poorly communicated, and in my opinion, the most deserving of a direct, honest, unhurried conversation. Over 500 commonly prescribed medications list dry mouth as a documented side effect. Over 500. For adults over 60 who take an average of 5 or more prescriptions daily, the cumulative impact on salivary function and on brain health can be profound and progressive. The drug classes most frequently responsible include antihistamines, antidepressants, blood pressure medications, bladder control medications, antipsychotics, and certain pain medications, including muscle relaxants. Several over-the-counter products also belong on this list. Most common drugstore sleep aids, many cold and allergy medications, certain antacids taken regularly. But here is what makes this genuinely dangerous. And this is the part most people have never once heard. There is a concept called anticholinergic burden. Think of it as an invisible fog that settles over the communication wiring of your brain over time. Multiple medications that each block acetylcholine, a key neurotransmitter essential not only for memory and cognition, but also for the nerve signals that trigger saliva production, create a cumulative neurological effect that is far greater than any single drug alone. The system was designed to handle one blocker, not 4 or 5 simultaneously. High anticholinergic burden has been linked in multiple large-scale studies following tens of thousands of patients over years and decades, to accelerated cognitive decline and significantly elevated risk of dementia. One major study found that individuals with high cumulative anticholinergic exposure over 10 years had a 50% greater risk of developing dementia compared to those with low or no exposure. 50%. Sit with that number for a moment. The dry mouth you wake up with every single morning is not the endpoint of this problem. It is the visible surface signal of something happening at a much deeper level. The mouth is easy to notice. The brain changes are silent. And here is the thing that I find most troubling when I think about it. The system that is creating this problem is not the result of any individual doctor's error or negligence. It is the predictable consequence of a model where each specialist treats one condition, writes one prescription, and never sees the full picture. A cardiologist prescribes a beta blocker. A urologist adds an overactive bladder medication. A psychiatrist prescribes an antidepressant. A general practitioner adds an antihistamine for allergies. 4 prescribers, 4 medications, each appropriate in isolation. The combined anticholinergic burden may be doing quiet, cumulative harm that none of those 4 providers has ever been asked to assess. No one connected the dots, because the system does not have a reliable mechanism for connecting them. I think of a patient in his mid-70s who described waking every morning feeling like he had swallowed chalk. He had been on the same medication combination for years. Stable, his chart said. No single prescribing doctor had ever reviewed the complete list in one sitting. Nobody had ever asked the whole picture question. A comprehensive medication reconciliation identified 2 drugs with overlapping anticholinergic effects, both of which had equally effective alternatives available that carried significantly lower anticholinergic burden. 2 substitutions. That was all. Within weeks, he noticed the difference. Within 2 months, he told me, "I wake up feeling like a normal person again. And I have to tell you, my thinking feels sharper than it has in years." That was not a coincidence. That was information reaching someone in time to matter. Now, I need to be absolutely crystal clear. Never stop or reduce any prescribed medication without your doctor's explicit approval. That is not what I am asking you to do. What I am asking is something entirely different and entirely within your power. Write down every single medication you take, every prescription, every over-the-counter product, every supplement, every occasional sleep aid, every antihistamine you take during allergy season. Bring that complete list to your next appointment and ask your doctor directly, do any of these medications suppress saliva production? And is there an alternative available that does not carry the same effect? That is not a confrontational question. That is not you challenging your doctor's judgment. That is you being an active, informed participant in your own care. Any good doctor will welcome that conversation. Any good doctor who has the full picture will want to have it. Oh, and one more thing I almost forgot to mention. Before you even get to your next appointment, if you are currently taking any over-the-counter sleep aid, check the label right now. Look for the active ingredient diphenhydramine. That is the compound in most common drugstore sleep products. It is one of the highest anticholinergic burden compounds available without any prescription. Low-dose melatonin at 0.5 to 1 milligram is a far gentler and better studied alternative for most older adults. If that one change is all you make after watching this video, it is worth it. Now, let me give you your complete action plan. Week 1 is going to feel like more effort than the result. I am not going to lie to you. You are changing habits that have built up over years. Some of them feel completely normal. That is exactly why they are hard to notice. But here is what week 1 looks like. Stop diphenhydramine sleep aids immediately. Switch to low-dose melatonin. Run a humidifier in your bedroom at 40 to 50% humidity every night. Front-load your fluid intake between noon and 4 p.m., 6 to 8 ounces with every meal and afternoon snack. Add a pinch of sea salt and a squeeze of lemon to your afternoon water. Brush with a fluoride toothpaste specifically formulated for dry mouth before bed. Try a nasal strip tonight if you suspect any mouth breathing. Some people notice a real difference in the first week. For most, 2 weeks is where it begins to click. Week 2 and 3. Your sleep should feel slightly more restoring. The morning dryness should be less sharp. Not gone necessarily, but less sharp. This is the moment most people either continue or stop. Stick with it. The discomfort confirming something is shifting is not a reason to stop. It is a reason to keep going. Week 4. This is where most of my patients call me with something close to surprise in their voice. Not dramatic transformation, steady improvement, and a clear sense that the direction has changed. Then this week, write that medication list, all of it, and bring it to your doctor. Today you have learned what most people never hear from anyone in a position to explain it clearly. 7 causes, the mechanism behind each one, a complete protocol you can begin tonight. And the question that could change the conversation at your next appointment. Your body was not failing you all these years. It was talking to you every single morning in the only language it knows. Now you know how to listen. Type, "I finished," in the comments if you watched the whole thing. And share this today, not next week, today, with one specific person. Your mother, your father, your spouse, a close friend, whoever came to mind while you were watching this. You may just give them the piece of information that changes everything. And before you go, next week, I am covering something that affects nearly half of all adults over 60 and has been quietly called the silent thief of morning independence. A study following over 8,000 seniors found that one specific morning habit increases fall risk by 53%. 53. Most people do it every single day without a second thought. That is next week. You will not want to miss it.